Okay. Hey, everyone. Thank you for all coming in. We'll sort of get started here in a couple of seconds. We've got people genuinely from all over the world, from North America to Europe and everywhere else in between, and Asia and so on. So if you guys can say hello in the chat as you've been doing and sort of give us a heads up of from where you are, it would be very interesting to certainly hear. In a second here, I'll start launching the presentation and we'll sort of get into it. There we go, Jupiter, Florida. Perfect. Welcome, everyone. Okay, so what we're going to talk about today is really, I think, a pretty groundbreaking idea in physical therapy, and that's really bringing EMG assessment and utilization into a streamlined way into the clinic outside of the lab, which I think really on this kind of scale has never been done, and especially with the tie-in into all the other investigative tools that Kinvent has to offer. So with us today, I think we have a really interesting sort of perspective on it from Christos, who is a PhD and a sports scientist with who is specialized in sports biomechanics. His area of passion lie in understanding the mechanics of vertical jump and running. He has spent a significant amount of time working with high-level basketball organizations in Greece. Currently, he's part of the research and development team for Kinvent, and his role involves pioneering research and the development of innovative solutions that address the need for athletes and physical therapy professionals. I myself am a physical therapist that practices in the sort of New York and greater metro area, working with quite a bit of years of experience, working at the Hospital for Special Surgery, as well as private practice, dealing with active adults and kids and youth and professional athletes as well. So thank you so much for everyone for joining us. I think we'll start off with Christos going over really the ins and outs of EMG, as I think many of us had gone over it when we were in school and maybe beyond. I saw some people that have a university email, so maybe you're in the lab. But for the rest of us, certainly having an overview of EMG really helps. So Christos, take it away.
Hello, everybody. Thank you, Alex, for the nice introduction. Today, we have to say also here that it's the first day of the official launch of the K-Myo sensor that Kinvent now has in its arsenal. So let's start. If it would be nice, we have a poll about who of you have recently used or whenever used an EMG device. So it will be nice to see some answers there. So as you are answering, let's start. So what is electromyography? As Basmajan and De Luca stated in their classic work, Muscles Alive, they said that is the study of muscle function through the inquiry of the electrical signal that the muscles emanate. We can summarize that in simpler terms, stating that EMG is a diagnostic technique used to measure and record electrical activity produced by the skeletal muscles. So if we are to go a little deeper, what is the EMG is detecting? Simply put, an EMG device detects muscle activation, a process that involves several biological procedures. Those procedures start with neural activation, which usually comes from the central neural system, where a motor command is generated to contract a specific muscle. This command travels all the way down to the motor neuron towards the muscle. So when the command travels through the axon, it will reach the neuromuscular junction, where it will release some chemicals called neurotransmitters, and then the contraction will be triggered in the form of electrical change in the muscle fibers, indicating an action potential to travel along the muscle fiber. So the action potential that triggers the release of calcium ions within the muscle fiber, initiating the biochemical response, will lead in a muscle contraction. This procedure is what the EMG sensor is sensing in the form of a signal, a very fast oscillating signal, which is the sum of all the action potentials that are passing beneath the electrodes. So how difficult is it to measure with an EMG sensor? There are two main categories of factors that will affect an EMG signal: the intrinsic factors and the extrinsic ones. So regarding intrinsic factors, some of them could be subcutaneous tissue, which is crucial, and it mostly refers to the fat that is underneath the skin. This kind of tissue can act as a low-pass filter, attenuating the high frequency of the EMG signal, and thus the EMG signal will come reduced to the electrodes of the EMG. Blood flow also can affect fiber type, fiber diameter, and also depth and location of active fibers. So, but intrinsic factors are fixed, and we have to live with them, actually. We cannot do many things about them. On the other hand, we have extrinsic factors where a proper setup and manipulation of the measurement can indeed provide a high-quality EMG data. So, extrinsic factors are electrolocation, which is crucial because it can affect severely the quality of the EMG signal. We will show after that slide a specific slide about how to properly fix and locate the sensor on the muscle. Sampling rate is also crucial because if you have not enough sampling frequency, you will lose crucial information about the muscle. Muscle crosstalk, if you will not put the sensor correctly, probably you will start recording signals from nearby muscles, and thus the signal will be contaminated. Skin impedance, it's crucial that the skin is clean, so it has little resistance and allow the flow of electrical current. And of course, movement artifacts. If the sensor is moving or the electrodes fast enough, it could produce some artifacts. So it's crucial to fix and stabilize the muscle, the sensor on the muscle. Now, here we can see how a raw signal of an EMG looks. It's those high frequency oscillations which are the activation period, followed by the near zero signal, which is the rest period. So, from all the factors that we saw earlier, and I'm talking about the extrinsic ones, let's expand a bit more on, for me, one of the most crucial, which is sensor location. Sensor location is crucial for EMG recordings. We know from research that there is a very strong effect on the data quality if the sensor is misplaced. So in the plot, we can see various locations of fixing an EMG on the muscle and the subsequent effect that they have on measurement quality. So if we attach the sensor near the innervation zone, which is the worst placement we can actually do, the signal, because the signal there will travel multidirectionally, causing the frequency spectrum to skew higher, and thus we do not have the actual signal. It's highly disturbed. The correct placement is along the midline of the muscle belly. Of course, we have to be very careful there because even some centimeters of offset right or left from that place could degrade the signal, introducing crosstalk from nearby muscles. And finally, also, it's improper to fix the sensor around the myo tendon junction because the signal will also decrease due to the very few and thinner muscle fibers. Now, sampling rate. It's also crucial because if you sample a signal lower than the frequency of the actual process, you lose crucial information. Now, regarding EMG, we know that the signal's power falls within the frequency of 10 to 250 hertz. So scientific guidelines such as those from CENIAM and ISEC recommend setting the amplifier band to a range of 10 to 500 hertz. So several researchers are even proposing even higher sampling frequencies. At least they state that at least 1000 hertz is proper, or even 1500 hertz is required to avoid any signal loss. Something that is also very important in EMG is maximum voluntary contraction. What we mean by that actually is a way to normalize the EMG signal because EMG is highly variable. The signal could be not totally, but highly different from day to day or even between session to session. Using a maximum voluntary normalization, which is actually producing an maximum isometric contraction to measure what is the maximum activation of the muscle, and then using percentages of that contraction, we can compare across different sessions or different muscles. So, preparing an EMG assessment with an EMG, there is a certain pipeline to have in mind when we are using EMG for measurement. So we have to place, as we said earlier, the electrodes in the appropriate landmarks. Also, it's nice and it will be useful. It could use measuring tape to be exact in the distances where we will fix the electrodes. We should be careful for skin preparation. We have to clean thoroughly with abrasive material and alcohol solution, remove any hair from the skin. Also, the electrode attachment, as we saw earlier, should be on the midline of the muscle belly. And after we do all of this, we could proceed with a baseline check of the signal, which has to be around 0 if there is no muscle contraction. And but all those steps is to create a measurement, an assessment that is, let's say, noise as possible free. When we are going to do some biofeedback training, for sure, all those steps are not necessary. And after the most necessary steps are the first, we have to place the electrodes on the muscle we need to train. And for sure, to make a baseline check of the signal and be sure that everything is according to plan. So now some basic EMG analysis questions that are usually out there. EMG to force ratio. It's natural for many people to have in mind that if the muscle activates more, it will produce more force. Now, this has some degree of truth in it, but unfortunately, although there is some correlation between both parameters, EMG and force, especially in smaller muscles in isometric contractions, unfortunately, it can greatly vary within individual muscles, joint angle and different time points of measurement. So it's not actually at the point very safe to try to predict force from muscle activation. So we have to keep that in mind, that EMG is all about muscle activation, and it's not giving us any clues about force. So, but still, that ratio can give us some information. The EMG4 ratio can be used to determine the neuromuscular status of a muscle. Within static isometric contractions with constantly increasing force output, well-trained muscles show a clear right shift, where atrophic or very untrained muscles show a left shift. So what that means is that with a given EMG activation, well-trained muscles could produce more force with less activation, and atrophic muscle will produce less force with the same activation. So something else we can do with EMG. The basic question we could answer with an EMG device is if the muscle is on or off. For example, here we have a gait cycle. The question we could answer here is at what phase in gait does gastrocnemius muscle have the peak activation? As we can see, gastrocnemius activation is slowly increased and reach its peaks during the toe off. And also, using multiple EMG devices in other muscles, we could correlate or relate, it's a better term, this activation to the sequencing of other muscles that are used in gait. So it's a very useful clinical tool to properly understand, to properly train or even understand gait patterns or general movement patterns. Another thing that we can do with EMG is assess coactivation. Coactivation is also known as co-contraction and refers to the simultaneous contraction of muscles that have opposite actions at a joint. For example, the bicep and tricep are antagonist muscles at the elbow joint. The bicep flexes the elbow while the tricep extends it. As we can see here, we have a signal from a young individual from the bicep and the tricep, and from an older individual from bicep and tricep. So when a young individual flexes his elbow using the bicep, there is minimum activation of the tricep. So there is actually, the coactivation is very low. On the other hand, when we check the signal of the older individual, we can see that for the flexion of the elbow, there is a significant tricep activation. So this is something that gives us an overview around movement quality. But coactivation in general, it's not something that is unwanted or undesirable, and it has to do with the context. So it has some functional utility, of course, regarding stabilization, transition between movements, and especially when we have to do fine movements that needs fine control, we have to use this kind of coactivation strategies. On the other hand, coactivation in, let's say, in running, improper coactivation around the knee will produce a a significant amount of metabolic cost. So in that context, is not a desirable trait. Also, there are cases in practice where we can see co-activation especially in the early stages of rehabilitation or motor learning after injury or an operation in the musculoskeletal system. And finally, we can use the EMG to assess muscle fatigue. As we can see in the plot, we have an EMG signal from a bicep brachii muscle. We did an isometric contraction here. And as we can see, as the muscle, as the time passes by, the muscle tries to recruit more motor units in order to sustain the load. On the other hand, below we can see that there is a shift and decrease in the median frequency of the signal, which means that the neural system is, let's say, setting slower commands for muscle contraction. So the described changes in EMG signal during the sustained muscle contraction are consistent with muscle fatigue. When we try to interpret those changes, it's essential to consider other factors such also here electrode placement, skin impedance, and signal processing techniques. And I think with that, I have to pass the ball to Alex.
Thank you, Christos. So look, I think the biggest thing for me as I started to when we started developing this, what I realized is just how much consideration for the science went into developing a clinical tool that is used outside the lab, right? If you look at all of the parameters and all the considerations, just the extrinsic factors that have to be considered between sampling rate, between preparation, between the sturdiness, the sensitivity of the sensor itself, the ruggedness of the sensor not to have a problem because of its own sensitivity. It really, I think it goes well beyond, creating a normal handheld dynamometer that's been done, by countless companies. I think this is really a big step forward. And having played with it now for probably 3 or 4 months with some of the earlier pieces, its earlier versions, I think it really changes how you view what you think what I thought I knew about muscle contraction in a lot of the cases, and I'll present some of them. I think they're quite interesting. So as we look at it, this is a study that before I ever knew about the K-Myo or its development, we did a study at the Hospital of Special Surgery looking at a technique of doing some stationary biking with a resistance band around the thighs versus just biking in general, trying to see if the tensor fasciae lata and the gluteus medius were more active with this particular exercise, and then compared it to some traditional glute med and TFL muscle strengthening exercise, traditional things that have been studied before. And I only bring this up because this took quite a bit of setup to, as Christos explained in depth, to assess the position of the electrode placement to various body types, various body size, various amounts of adipose tissue, various amounts of body skin hair. But what it did give us is it gave us an idea of what does it look like, and what you can see, and the data here is not as consequential, although I'll sort of pat myself on the back. We did create, an exercise that if you're doing some stationary biking with the band, the level of activation of your glute med in blue is significantly higher than it is without the band. So from a clinical standpoint, this was kind of a really interesting thing to look at, but it took months of preparation and booking lab time and being able to do that, to look and say, which we sort of already thought was true, in order to get early post-op glute activation for post-op hip patients where they couldn't do, whether it's hip abduction, isometrically, or active range of motion, they could bike, and this was a way to get some of that activation. But the question that I always had after this was, well, how do we take this outside the lab? I mean, like I said, this was a fairly painstaking study that involved not only time but money to do. And lo and behold, we have here, a way to fit a lot of that information clinically into a streamlined visit, into a high-paced or a one-on-one clinic session. So I think, if you have a full motion lab, if some of you work in a full motion lab, that's fantastic, right? But most of us work in a scenario where you have 30 minutes. Maybe you're lucky enough to be in a clinic where you have 45 or 60 minutes with a patient. But no matter what, you have to have the tools at your disposal, and your visits have to be streamlined so that you and the patient get not only assessment done during that session, but also intervention as well. And what are we able to gather from the EMG data that we can get with the K-Myo? And what I'll show some examples of, early muscle activation, neuromuscular re-ed that we've all tried to do in the past. As Christos says, antagonist activation to reduce guarding or potentially want to have some co-contraction, selective muscle activation with loading phases of rehabilitation and overload, and neuromuscular training with higher loaded positions, where normally we aren't focused on measuring strength objectively within a visit or within a certain phase of the rehab, where now we can really become a little bit more objective about it. And so what we look at, how do we do that? We have biofeedback. We have various exercises that you can utilize, not just the EMG device, but also force testing combined with the EMG. As Christos was saying, you may have a very high EMG signal, but the force becomes lower and lower. And to us, even though we're looking at the signal and say, wow, great, the muscle's activating, you're actually seeing a significant decline in that force. And to be able to see what muscle looks like fatigued and the force that it's able to generate at the end of a session or at the end of a workout versus at the beginning, I think is critical. And then, of course, applying this to a biofeedback. And what I want to do now is just get a sense from folks, and thank you for answering the other poll, but can we get a sense from folks on how often you use biofeedback, or if you use biofeedback in your practice? We'll put that up. Because I think, it's important that we realize that our patients, our clients, and we want to make sure that they are both engaged for our sake, and for the sake of the visit, but also for their ability to utilize the time they're spending with us efficiently. So good. It looks like everyone uses it some. Thankfully, nobody uses it never. So that's good. So we've got the majority.
Alex, if I can say that what you said is crucial about biofeedback, because I think it's and with EMG, it's a highly underestimated feature of electromyography, and it could provide a significant impact in the rehabilitation and therapy of musculoskeletal and neuromuscular therapies.
Mm-hmm. Yeah, I agree. I think there's such a drive right now for objective measures to be taken, and rightfully so. It really is able to track our progress or lack thereof, change the direction our rehab is going, have those peer-to-peer conversations with insurance companies. But at the same time, understanding what the patient is trying to do and understanding why they're not doing it, I think it is critical to improving our ability to treat them. So when we look at a couple of examples, we have two patients. So one, and I'll just sort of read them out, two situations I think we've all at some point faced. The patient that comes in non-operatively and says, look, I'm really strong. I work out all the time. There's no way my rotator cuff is weak, or I played, an overhead sport. My shoulders are really strong. I'm good. And you say, okay, so let's objectively test you. And the patient is using everything they possibly can to perform a external rotation, whether seated or standing, against a stabilized dynamometer. But you can visually see, or you can palpate that there really isn't much external rotation external rotator cuff contraction, whether you're looking at the and looking at the posterior shoulder at the infraspinatus, or you're trying to sort of visualize where the teres would be. But you can see that they're just pulling with their body, or they're extending their forearm or their wrist, and seeing force generated that is not genuinely coming from the external rotators. Or you have the opposite end of the spectrum, where you're barely able to document any force, where someone is in that early post-op phase and you're trying to look at some isometric contraction, not necessarily in order to document objectively how strong they are, but to give them some sense of, okay, this is where we are. Let's maybe do a little bit of biofeedback, but you're trying to generate a little bit of contraction. And they're pushing again with all of their might, but they just cannot find this muscle. And any force that's generated is just too low. The threshold is too low of the overall force into an actual dynamometer, or into, you know, a towel at the wall like we all do, in order to utilize that objectively. And I think the biggest danger here is no matter how much stabilization is done, it's just not sufficient for both of the results to be reliable, and their inability to contract the right musculature. And if you and the patient agree that the number that you got on that dynamometer, or your hand, or whatever it is you're using, is a valid test, you end up setting yourself up for failure, and you end up setting the patient up for failure, because everything is going to be built off of that notion that what you just tested at baseline is valid. And so if that person that comes in that's nice and strong and they can really push hard, but it doesn't actually come from external rotation, if you record that as valid and you guys agree to it, now everything builds off of that. Well, it must not be my external rotators. If we aren't able to assess the patient's control of the muscle early, there's no way we can load it later and overload it to actually create strength. And what I want to show is a little bit of a video. Give me 2 seconds, I'll pull it up. And so what the video will show is, I'll just pause it. So we've got the K-Myo on the infraspinatus here. I've tried to get it more midline. I probably could do a little better job with the orientation of the pad itself. And I think this is where anatomy obviously plays into effect, to understand where the attachments are, where you want to be along those fiber types. But what I've set up is a very simple, there's a stabilizing strap here. Actually, you can't see my mouse, but there's a stabilizing strap there. He's going to pull with his left arm into external rotation. This is a, not recently, but this is a surgically repaired labrum that he has been exercising and doing well. And when I saw him, he just had no ability to really generate power overhead, and he couldn't quite understand why. And the big question was, why am I not doing it? I'm really strong. I've been working out. I'm 4 months or so out of surgery. Why am I not able to generate force? And what you'll see as he starts to push is you'll see a very difficult time actually producing what Christos sort of showed before, which was a nice steady contraction. I'll just show it one more time. See if we can. Yeah. So what we'll see is a fairly poor ability to have a consistent contraction in those external rotators. But you can see his body is constantly really trying to pull out with everything he's got, and he's leaning into it, and he's doing everything he has. So he sort of has strength and he's jerking into it, but he just can't quite get the external rotators to fire. And that's the biggest issue that I think we see, is we start building upon a false narrative that's produced early on. Feel free, obviously, if there's questions, we'll obviously take them at the end, but if you guys have anything, feel free to put it in the chat as well. So then you have your next patient, right? So this is a hip or lumbo-pelvic strengthening assessment. The patient is working on glute med strength and reducing TFL or rectus femoris compensation to produce hip abduction. And certainly more functional, those non-op patients, those stronger patients, are able to sort of cheat it. And we've all seen this. Patients will sort of externally rotate their leg, and they'll roll their hip, and they'll try and create sort of what looks like hip abduction, but isn't actually glute med activation. And look, we can argue certainly whether it's glute med or a combination of glute med and TFL, but whatever muscle you deem important, in the pelvis to stabilize the hip joint in single leg stability, to unload the lumbar spine and create lumbopelvic rhythm and strength. That's the muscle I'm talking about, right? So I believe it's glute med. You may believe it's something else, but that's really what we're talking about here. And the question is, the less apparent compensation that you have, if somebody is lean and muscular, you may be able to rectify that. You may be able to notice it. But in a larger person, you may not, and they may not either. And it's very difficult to genuinely get a sense of, are you actually getting the contraction you're looking for? So again, what I'll do is show, give me 2 seconds here. What I'll show is the assessment. What you see here is a strap around the table. We've got the K-Myo right on top of the glute med there. And he's going to go up and he's going to be pushing directly into it. Now he's got pretty good ability to sort of maintain that contraction. And as he goes, you have a nice amount of steady contraction there. And then the end result will be a graph that cleans up a little bit of that noise that Christos was talking about. But making sure, this is after quite a bit of training, making sure that patient is pushing into the abduction and the activation you're looking for is critical, because off of that, we can begin to actually test that muscle because they know what it feels like, not just because they put their thumb on it or because we directed them to. It's a visual, it's an auditory and tactile feedback into it. So what else? What else can we sort of use it for? So here's one that, if you ask I think a physical therapist about biofeedback, the first thing that I think of is quad activation after knee surgery, whether it's total knee, arthroscopy, ACL, whatever it is. And I think finding quote unquote their quad is difficult. And I think for us, if you have a young athlete, you can see whether it's firing. If you have a larger patient that's muscular, again, you likely can see it's firing. But what about the older folks? What about the patients that are a little larger and a little less muscular? Can you really assess that there's good muscle contraction? And even if they are having contraction, or if let's say you use the K bubble and you have a pressure sensor under their leg, or you have a dynamometer under their leg and you're measuring how hard they're pushing down and I'll show that in a second, can you guys hear me? Can you hear me? Are we okay? Okay, I just saw something in the chat. All good? Okay. All right.
Yes, we can hear you, Alex.
Okay, sounds good. Anyway, so what about the patient that's looking at doing those quad sets? If you're measuring the amount of force produced into the sensor underneath their knee, do we know that is produced by knee extension via quad contraction, or do we think that potentially you have hip extension going into it from the extensors from the glute or from the hamstring? And what I want to show here is you have the K-Myo on the quad, more on the medial side. I'm targeting vastus medialis. I will be honest, I don't shave my patients before I put the K-Myo on. I know. I mean, there's probably going to be a little middle ground, and we're going to have to figure out how much of an issue we're going to have with that. But what I can see here is I can see how much of their contraction is actually linked to the pressure on top of the ball. Now, what you could do is you can link the K-Myo with a dynamometer underneath where the yellow ball is, in order to look at force produced and quad activation. And then you're really sort of next level looking at what point does, as we said before, does their force begin to decrease and their activation starts to increase, and what you're looking at is actual quad muscle fatigue. And that's a really interesting stat or metric to look at when you think about early post-op knees. But what you can see is this patient learning muscle control. And what I want you guys to look at is in the beginning of contracting, right here. Does that quad look like it's contracting? And just keep looking at it, because this graph will continue to go up, and you tell me if there's a drastic change in the amount, in visually, whether that muscle is contracting. Right? His EMG activity on this chart goes up dramatically. It's fairly similar, and then he really finds it. He figures it out. But his quad didn't all of a sudden whip up into shape. And that's my point, is that you aren't able to always tell. If someone is a 15-year-old, 4x100 sprinter, you probably can tell. But if somebody is a 35-year-old, parent and weekend warrior, and they probably maybe have a couple extra pounds on them, it's going to be difficult to figure out whether they're just shaking their leg or actually contracting their quad. And I think that's very important for us to kind of be honest with ourselves about. So we'll show it again. So here he is, he's sort of jumping the gun a little bit. Now he's sort of figured it out, and it's a little bit more even. And you can start seeing how that muscle contraction. And again, but as he pushes, are we sure that that contraction is coming? I'll just show it one more time. Are we sure that that contraction is coming from the quad or the glute into extension? And the only way, to me, that we know that at least some degree that's coming from the quad is with the K-Myo. And if we put two channels on, and we actually put one on his hamstring or on his glute, we can see if there is, as Christo said before, is there reciprocal inhibition, if that quad is on, or if we're a lack of co-contraction, I guess I should say. If the quad is on, the hamstring or the glute is actually off. And I think, again, these are incredibly useful tools to just put into your tool belt when you're doing rehab, so that you're not just sort of doing the same old thing and hoping and assuming the best, but you're really figuring out, is it what I think I'm seeing, is what I think I'm prescribing to this patient actually what's happening with that patient? So then we look at biofeedback regression, right? And so what you want to do is, we want quad contraction. And early on, I think it's fairly obvious. You can do biofeedback in that very position right there, right? You do a quad set. There's a couple other devices out there that you can sort of do it that don't have the same frequency, but nonetheless, it's an easy setup. But what about higher levels of quad contraction? What about different patients or different positions that you want these patients on? A squat position where we want a little bit more selective quad activation on a step down or a leg press or a squat. And we want them to feel what the difference is when they shift their weight towards that leg versus away from it, when they shift weight a little bit more forward on the step down versus away from it. And to progressively be able to figure out, let's just say, for example, I'll show you, I'll sort of cut to the chase here. Stand by. Okay, so what you see here is we're progressively loading a patient with a leg press, single leg press. And at some point, this patient, if they are sort of rehabbing their knee or their hip, I suppose, but certainly their knee, the load becomes too much for a weaker quad to be able to do, so you begin to see compensation. So in this particular moment, we found the appropriate load where he can still press through the ball of his foot and control. Probably could have made that slide a little longer. What you can see is he's not moving. It's an isometric contraction, but he is able to selectively increase or decrease the amount of quad activation that he's doing. And that is genuine neuromuscular control, right? Because his body's not moving, the load is not changing, but he is mentally able to assess and increase quad activation and then decrease quad activation. This is not force. This is just EMG activity. And I think that's a big change in how we think about neuromuscular control, because I always think of it as how much force you're producing, but that's not control. That's just the resultant of multiple muscles contracting to produce a force. That is not muscle activation. It's just force creation. This is a completely different ballgame, and I think if you're in the business of understanding what your patients are utilizing to produce the force, this is a game changer. Not just in the beginning with quad sets and external rotation, but in high-level patients or highly motivated patients to produce the kind of force, a kind of activation that produces the force you think you're seeing. Let me just play that one more time. So I think, to me, this was probably the most eye-opening thing when you can start to think about the way that you're creating the force you think you're seeing or that you are seeing, and can that patient reduce or increase the amount of muscle activation, selective muscle activation for that force? Anybody have an idea of how many times I said muscle activation? 50. So anyway, I think, as an introduction, I think, Christos certainly put together a really high wealth of knowledge. There was like 2 people that answered that they do use EMG. So to them, good review probably. For the rest of us, really kind of interesting and very knowledgeable to understand just how sensitive these devices are and how difficult it is to bring that into the clinic. If you guys obviously want more information, take a look at the pop-up there. But the other benefit is you're tying in this myo EMG activity into the same profile that you're doing your force data with on the plates, on the push, on the pull, on the link, on the bubble, on all of those things. So that is really, like I said, it's not just EMG activity in a lab. Okay, great. It's streamlined activity. How well are you doing? How well are you controlling and activating the muscle you're doing? So would love to hear some questions. Would love to answer them. I'm sure more for Christos because that was a lot more sort of informational stuff, but I'm happy to take questions as well.
Nice. Thank you, Alex, for the practical aspect. It was really enlightening.
So the question, the question in the chat, which I think is really valid because, given the background, what I think would be very, very good is as we get more and more development of the K-Myo, what we're going to be able to do is similar to how you have the setup picture of a knee extension with a link or a shoulder flexion with a push. I think that what we will have is best practice placement of the K-Myo for the various muscles that you're testing, the generic muscles that you're testing. Not obviously for, digiti minimi or something, one of these sort of things, but certainly for the heavy hitters, right? The quads, the hamstrings, the glutes, the external rotators. I think that's critical, and you'll have all of those things listed in there.
Exactly. So, Dominic, we are also planning to release material in our app about the proper placement, the correct anatomical landmarks when you have to put the sensor. So don't worry, we will have you covered.
So the question, Jose, I think is interesting. Similar to how Kinvent was able to utilize 2 push dynamometers in order to perform a Nordic hamstring, or the K-Move with the plates to get a higher level of analysis in the squat or kind of movement jump. On the back end, this is why, like I said, it's so important to have this in one app, in one profile. You're linking on the back end the data from a force sensor and the data from an EMG sensor and processing that through, which we aren't able to necessarily do without building some massive API. So they can be connected because Christos will give you the more in-depth information, but because on the back end, Kinvent's recognized these are the most important or the most utilized movements and tests that we're doing. What tools do we need out of our arsenal to be able to create them? We need to be able to link them together to give clinicians the information they need from them. But please.
Yes. So, Jose, to answer your question, you can connect a lot. 3, 4, 5, 6 with the V3 devices. You can do you can do that. And also you have to have in mind that every sensor has 2 channels, so you can test 2 muscles every time. So I think I hope that answered your question.
I'm not exactly sure. The application itself is the K-Physio application, and it's quite robust and has, I mean, pages and pages and pages of information that's sort of neatly organized by position, muscle group, device, action. But the application itself, that's the thing that sets it apart, is the software is moldable to what clinicians need to do. The hardware is the hardware. I mean, that's updated obviously some points, but the software is what's updated more frequently in order to utilize the forward-thinking hardware they have.
Exactly, and as time passes by in software, new features will come, and the analysis and biofeedback protocols will be coming more advanced each time.
Yes. So you will get results in real time, like you were just seeing when I was showing the videos testing. As soon as those results pop up on your screen, you have the option of creating a PDF, redoing the test, or going directly into biofeedback. There's a button and it goes directly into biofeedback. And now you're utilizing that data in order to do the biofeedback. So I'm not exactly sure what you're referring to. I'm happy to take the question. If you want to email me, I'm happy to sort of take a look. Great. Well, look, everyone, thank you so much for attending. I think this was incredibly informative for me. I hope it was for you as well. Any other clinical questions, certainly email the info folks for more information at Kinvent. And we'll look forward to seeing you at our next webinar. Thank you.
Thank you.